Okay, guys, I'm between you and lunch, so let's get this going here. All right, and I have 25 questions for you. Okay, so let's go ahead and get started. So, question one, a formula-fed 6-month-old girl presents after 2 separate episodes of severe vomiting without other sign of illness or sick contacts. Both required ER care and IV fluids, and she responded without other treatment each time. She also had CBC with diff that had elevated neutrophils. The only common factor the parents can recall is that each time she was fed rice cereal 4 hours before the onset of vomiting. So, what is the most likely diagnosis? Key in your answer between these conditions: severe GERD, viral gastroenteritis, eosinophilic esophagitis, food anaphylaxis, and food protein-induced enterocolitis. Okay, you are correct. This is FPIES, or food-induced enterocolitis. The classic presentation: severe, often dehydration-type vomiting requiring fluid resuscitation 3 to 6 hours after eating the suspected food. And the fluid resuscitation seems to stop the reaction each time. It's an immunologic reaction, but the mechanism isn't well known, possibly T-cell mediated, and IgE is not involved, so it's not anaphylaxis. And allergy skin testing is usually negative. You can often see a neutrophilia there, although the mechanism of that is also unclear. Keep in mind that milk and soy are the most commonly implicated foods, but solid foods can be the triggers as well, and often things that are unusual to be allergens, like rice and sweet potatoes and bananas and poultry. Okay, next question. Which test is most helpful to evaluate cell-mediated immunity in a 3-year-old child with recurrent infections, chronic diarrhea, and failure to thrive? A, quantitative immunoglobulins. B, immunizations and then specific antibody titers 6 weeks post-immunization. C, nitroblutetrazolium test. D, PPD and controls. Or E, measure complement levels. Go ahead and key in your answers now. Oh boy, oh boy, oh boy. All right, so we're talking cell-mediated immunity in somebody with failure to thrive, chronic diarrhea, and recurrent infections. Say this is somebody with a DeGeorge syndrome or something like that. Which of these tests actually measures cell-mediated immunity? Delayed hypersensitivity skin testing. So when you're looking at cell-mediated immunity, delayed hypersensitivity skin testing, you can also look at T lymphocyte counts by flow cytometry or do mitogen stimulation testing. Keep in mind, antibody tests and those measuring immunoglobulins are in the antibody category and would not be relevant to cell-mediated immunity with failure to thrive, more with recurrent bacterial infections. And again, the complement measures that pathway that tends to give people recurrent Neisseria infections or recurrent bacterial infections or autoimmune disease. Okay, let's try the next one. Okay, an 8-year-old boy initiated a 10-day treatment with oral amoxicillin 12 days ago, and 2 days ago he developed fever, malaise, arthralgias of multiple joints, dark urine, and urticaria. Which of these would be the treatment of choice? A, Augmentin for 10 days, B, oral Benadryl, C, prednisone, or D, stop all medications, admit and observe. Go ahead and key in your answer now. Oh boy. All right, what is this, guys? Serum sickness. Serum sickness, very responsive to oral steroids. So give this person prednisone, okay? And it will prolong burst taper of oral corticosteroids, the treatment of choice, plus supportive care with antihistamines for itching. So yeah, if you see somebody with serum sickness, give them high-dose steroids. It works like magic. Question 4, a 15-month-old female has been hospitalized for several serious infections secondary to Staph aureus, including osteomyelitis, hepatic abscess, and pneumonia with pneumatocele formation. Which of these four is the most likely diagnosis? A, Wiskott-Aldrich syndrome, B, selective IgA deficiency, C, leukocyte adhesion deficiency, or D, chronic granulomatous disease? Go ahead and key in your answers now. Yep, this is CGD. Okay, CGD is a phagocyte disorder, and basically you get recurrent infections with Staphylococcus, other organisms, but you classically get recurrent lymphadenitis, hepatic abscesses, skin infections, osteomyelitis, pneumonias. You can also get some unusual organisms like catalase-producing fungi like Candida or Aspergillus, Serratia or Salmonella, Nocardia, Burkholderia, a bunch of oddball stuff. Wiskott-Aldrich syndrome gives you that triad of recurrent infections, eczema and thrombocytopenia, selective IgA deficiency, kind of mild infections with maybe ear infections, but nothing deep tissue or pneumonia. And in leukocyte adhesion deficiency, recurrent infections without abscess formation because the leukocytes can't adhere to anything, and so they can't get to tissues, and so you don't get any pus. Question 5. You're asked to see a 15-year-old female who has acute onset of bilateral flank pain and hematuria, and she's receiving an extended course of IV antibiotics for a staph infection. Which is the most likely cause of these symptoms? A, adverse reaction to vancomycin, B, adverse reaction to methicillin, C, adverse reaction to cefazolin, or D, renal stone? Go ahead and key in your answers now. Oh boy. Okay, what does this person have? Interstitial nephritis. What's the most common cause of interstitial nephritis amongst drug reactions? Methicillin. You will be on every board exam you ever take in your life. Okay? So this is an adverse reaction to methicillin. So interstitial nephritis, antibiotics can occur with any drug, but noticeably common with methicillin. Know that factoid, okay, guys? Okay. Again, it was the most common answer, but still, not the majority. Okay, next, a 5-year-old male is admitted with his 3rd episode of bacterial meningitis. Each time it's grown Neisseria meningitidis. Which of the following tests is most likely to find the underlying immune deficiency responsible? A, nitroglycerin test, B, quantitative immunoglobulins, C, flow cytometry for adhesion molecules, or D, CH50? Go ahead and key in your answers now. Yes. Okay, recurrent Neisseria infections, think complement disorders. It's going to be on your boards, okay? It's going to be there. Okay, again, children with deficiencies of certain complement components, especially C6 through C9, will present with recurrent systemic Neisseria infections, and CH50 is the best single routine test for measuring complement system function. All right. Question 7. A 16-year-old girl presents with a 3-month history of daily urticaria and pruritus, and that's how you spell pruritus, by the way, guys, and occasional episodes of lip and eyelid swelling. Which is the most likely cause for her urticaria and angioedema? A, it's just idiopathic. B, hidden food allergy. C, contact allergy due to dust mites or a family pet. D, an underlying autoimmune disease. Or E, C1 inhibitor deficiency. Go ahead and key in your answers now. Whoa, okay. It's probably just idiopathic, guys. Okay. Okay, C1 inhibitor deficiency does not give you urticaria. Does not give you pruritus. It gives you painful swelling in areas of trauma. Okay. So, again, this is chronic urticaria, defined as urticaria lasting more than 6 weeks in duration. And over 90% of pediatric patients with chronic urticaria are described as and classified as idiopathic, whether or not with no underlying allergy or identifiable condition. Autoimmune disorders can rarely cause chronic urticaria and angioedema, and hereditary angioedema, isolated episodes of painful swelling, unlikely to have urticaria or pruritus. Okay. Question 8. A 12-year-old girl with known ragweed hay fever symptoms in the fall season complains of an itchy mouth when eating a particular food. Name the food. A, peanut, B, hazelnut, C, watermelon, D, apple, E, corn. Go ahead and key in your answers now. Okay, all right. Now, this is pollen food oral allergy syndrome, and certainly we know that for people with birch pollen tree allergy in the spring, this occurs with foods like apple, pear, plum, and cherry. For ragweed patients who are symptomatic now and coming forward into September, this occurs with bananas and melons. So the correct answer is watermelon, yes. Okay, question 9. You're seeing a 10-year-old boy in the late spring who has 4-week history of sneezing, nasal congestion, and rhinorrhea. You suspect he has allergic rhinitis. Which single medicine would be the most effective in treating his chronic nasal congestion? A, an oral decongestant, B, an intranasal corticosteroid, C, an intranasal antihistamine, or D, an oral antihistamine? Go ahead and key in your answers now. Yep, if you're looking for the most bang for your buck and the most effective medication for chronic nasal congestion associated with allergic rhinitis, clearly it's intranasal corticosteroid amongst that group. Certainly, yeah, you can use antihistamines, leukotriene receptor antagonists, or intranasal corticosteroids, and guidelines from the American Academy of Allergy recommend intranasal corticosteroids as first line, and oral antihistamines, leukotriene receptor, do improve symptoms compared with placebo, but clearly comparisons between intranasal steroids and the other medications find the intranasal corticosteroids to be most effective. Okay, question 10. A 15-year-old patient with spina bifida had an acute episode of hypotension, bronchospasm, and diffuse erythema 45 minutes after starting a surgical procedure during which she received general anesthesia. Which is the most likely causative agent for the reaction? A, antibiotic she received 1 day prior to surgery, B, anesthetic inhalant, C, colloidal intravenous fluid, D, iodine cleansing solution used prior to surgery, or E, latex rubber. Go ahead and key in your responses now. Okay, yep. Latex rubber would be the answer to this question, although certainly in most centers that deal with these patients now, they don't use rubber in the operating room, but for the purpose of this question, yes, the correct answer is the most likely would be latex rubber. And the key is the fact that this person had spina bifida. If they had bladder exstrophy, that would also be a clue that this person has latex allergy. And again, over 50% of patients with spina bifida have latex allergy, so we just put them in latex-free environments if we know what we're doing. Question 11. The rash most commonly associated with celiac disease is A, atopic dermatitis, B, erythema marginatum, C, erythema multiforme, D, pyoderma gangrenosum, or E, dermatitis herpetiformis. Go ahead and key in your answer now. Yeah, we didn't cover that yesterday, did we? Yeah, most of you got it right. Dermatitis herpetiformis is associated with celiac disease. So atopic dermatitis, usually an allergic disease, especially food allergy, but also can be seen in certain immune deficiencies, notably Wiskott-Aldrich syndrome. Erythema multiforme, typically associated with certain drug allergy reactions and infections. Erythema marginatum with Lyme disease, pyoderma gangrenosum with inflammatory bowel disease, and dermatitis herpetiformis with celiac disease. Question 12. A 12-month-old infant was diagnosed with X-linked agammaglobulinemia, which is a recessive B-cell immune deficiency after suffering multiple sinopulmonary tract infections such as otitis media, sinusitis, and pneumonia. What is an appropriate treatment for this patient? A, plasmapheresis and broad-spectrum antibiotics, B, intravenous immunoglobulin, C, prophylactic antibiotics, or D, enzyme replacement therapy. Go ahead and key in your answers now. Okay, yeah. Immunoglobulin replacement, you know, this person's missing antibody replacement's what's missing here. Yeah, for X-linked agammaglobulinemia, again, just to review, usually delayed onset, 4 to 6 months, due to maternal IgG finally waning away, and treatment involves IVIG, broad-spectrum antibiotics for infections, but the IVIG is most helpful in preventing the severe acute bacterial infections and bronchiectasis that they're at risk for developing. So initiate treatment early and maintain it lifelong unless this patient somehow gets immune reconstitution. Enzyme replacement is relevant for one condition, which is adenosine deaminase deficiency. There is a product called PEG-ADA that provides bovine ADA conjugated with polyethylene glycol that can actually replace the adenosine deaminase that's missing and give them a better immune function. Question 13. A 2-week-old boy is admitted to the hospital for seizures and found to have hypocalcemia. Physical exam is significant for hypertelorism, mandible hypoplasia, and a loud systolic murmur. What immunodeficiency should you suspect? A, ataxia telangiectasia, B, X-linked hyper-IgM syndrome, C, DeGeorge syndrome, or D, severe combined immune deficiency. Go ahead and key in your answers now. Yep, it's DeGeorge syndrome. Remember, DeGeorge syndrome has the wonderful triad of hypocalcemia, cardiac malformations of the aortic arch, and absent or diminished thymus development causing recurrent infections. Typically, most commonly associated with deletion in chromosome 22q11. You also get some facial dysmorphisms because not only is the 3rd and 4th branchial pouches infected, but the 1st and 2nd are usually affected as well. And so you may get some of these hypertelorism, short philtrum, low set ears, mandible hypoplasia type features. Ataxia telangiectasia typically has the triad of oculocutaneous telangiectasias. They also have neurologic manifestations with cerebellar ataxia, and they get gradually progressive infections. So they typically present a little bit older. Their telangiectasia is usually about 3 to 6 years of age, regression of motor milestones with the cerebellar ataxia, and then again, typically later onset infections with that condition. X-linked hyper-IgM, basically they get recurrent infections and persistent elevated IgM and SCID, a variety of different gene defects that tend to cause profound defects in antibody and cell-mediated immunity, and not associated with any hypocalcemia. And these people typically present in infancy like this patient would present, but typically more with failure to thrive, diarrhea, and recurrent opportunistic infections. Question 14. A 14-year-old female with persistent asthma has an elevated total serum IgE over 2,000 nanograms per ml with normal around 150. A history of transient pulmonary infiltrates on chest radiographs and now has proximal bronchiectasis on a CT scan of the chest. What test would best help diagnose her underlying disorder? A, a skin test to aspergillus, B, skin test to cow's milk protein, C, sweat test, D, lung biopsy for non-caseating granulomas, or E, sputum culture for histoplasma capsulatum. Go ahead and key in your answers now. Yeah, we didn't go over this one either yesterday. But most of you got it right. Because what is this condition? ABPA, allergic bronchopulmonary aspergillosis. Yeah, it complicates chronic pulmonary diseases like asthma and cystic fibrosis, and maybe up to 10% in some severe cases. And it gives you colonization with aspergillus, and it produces an exaggerated antibody response causing bystander tissue damage in the airways. So these patients will get classic central bronchiectasis and recurrent bronchospasm, and they have very high levels of total serum IgE and positive skin tests to aspergillus. It's treated with corticosteroids. And again, the goal is to treat exacerbations with high-dose steroids and then provide low-dose steroid treatment to prevent or minimize bronchiectasis. The classic presentation is an elevated serum IgE above 1,000 with these wandering infiltrates on chest X-ray, proximal bronchiectasis on CT, and positive skin test. So it's not an aspergillus infection, it's a colonization in somebody who has an exaggerated immune response to aspergillus proteins. Okay, 17-year-old boy has a history of an adverse reaction to radiocontrast media 2 years ago, which included diffuse pruritus and urticaria accompanied by hypotension. Which statement is true regarding his adverse reaction? A, a history of this type of reaction is an absolute contraindication for further administration of radiocontrast media. B, he should avoid radiocontrast media and iodine, such as an iodine cleaning solutions and shellfish. C, he should receive high osmolar, high ionic radiocontrast for the next procedure. Or D, he should receive antihistamines and prednisone prior to the next procedure with radiocontrast. Go ahead and key in your responses now. Yep. Radiocontrast media reactions are anaphylactoid and not IgE mediated, so there's no cross-reaction with the shellfish thing, okay? Anybody who's asking you that in radiology doesn't know what they're talking about, okay? There is no cross-reaction between shellfish and radiocontrast. But radiocontrast media, but based on the ionic and osmolality of the material, is more likely to cause direct mast cell degranulation and release of histamine. And so these patients should receive low osmolar ionic radiocontrast and be pre-treated with antihistamines and steroids prior to the next procedure, and they should tolerate it well. So again, these are non-IgE, so they're not related to any allergy or food allergy or anything. And the mechanism is different because it's just a direct mast cell degranulation, not with the amplification mechanism that IgE provides for true anaphylaxis. So it involves degranulation of mast cells and histamine release with pruritus, urticaria, and hypotension. And again, these are what we call anaphylactoid reactions. Risk factors include patients with asthma and allergic diseases, use of beta blockers in particular, and a previous reaction. And high-risk patients should receive prophylaxis to reduce the risk to a future reaction to less than 1% by using prednisone, antihistamines, and low osmolar and ionic radiocontrast. Question 16. While a 14-year-old patient with spina bifida is waiting to see you for a well child visit, she decides to have something to eat. Within 10 minutes, she starts experiencing diffuse hives, shortness of breath, and wheezing. Which food did she eat? A, strawberry, B, banana, C, apple, D, peach. Yep, it's banana. Yeah, there's a latex fruit syndrome, and the ABCs are avocado, banana, and chestnut. They seem to have cross-reactive proteins with the latex rubber proteins, and can cause anaphylactic type symptoms. Unlike the pollen food allergy, which is just an itchy mouth, this latex food is a true anaphylactic allergy, and positive skin tests can be demonstrated to these foods. Again, bananas, avocado, chestnut, and kiwi are the most common for these. And there are some other foods as well that are much less common. But about 30 to 50% of people with latex sensitivity have this latex food allergy syndrome. Okay, question 17. A 10-year-old boy comes to your office for an evaluation of pruritus and a rash. The rash has been present for the past 10 days, along with mild symptoms of an upper respiratory infection. Physical exam significant for an uncomfortable boy who's scratching throughout the exam, and his skin is remarkable for diffuse urticaria. He's never had urticaria before. What's the most likely cause? A, a food allergy, B, an allergy to an airborne pollen, C, the viral infection, D, contact reaction to a new soap, or E, pet allergy. Go ahead and key in your answers now. Yep, probably just a viral infection. Does it all the time. Yeah, acute urticaria can be caused by allergic problems or other mechanisms, and again, common triggers would be foods, medications, inhalant allergens, infections like colds and stuff. Autoimmune or collagen vascular disease, physical things like cold or heat or pressure, but in somebody without a previous history of allergy, and it's just a 10-day thing during an infection, probably just the virus. Yeah. Keep in mind the duration can be helpful. Usually food reactions are pretty self-limited. You eat shrimp, you break out in hives, usually by the next day it's gone. This kid had it for several days, so it's most likely related to the virus. Question 18, you're seeing a 10-month-old boy with severe eczema who recently moved to your town, and his mother mentions that he has had recurrent infections requiring antibiotics, and that he has a history of easy bruising and purple rashes. What's the most likely immunodeficiency here? A, X-linked hyper-IgM syndrome, B, complement deficiency, C, Wiskott-Aldrich syndrome, or D, leukocyte adhesion deficiency? Go ahead and key in your answers now. Yep, it's Wiskott-Aldrich syndrome. Yeah, it gives you that wonderful triad. Again, board examiners love triads, remember, of recurrent infections, eczema, and thrombocytopenia, usually presenting before age 1. And they can get prolonged bleeding after circumcisions or bloody diarrhea, or they can just get bruising and petechiae, and typically this is related to the thrombocytopenia that's there. Oftentimes that needs splenectomy. The other conditions, X-linked hyper-IgM, basically, again, recurrent infections is the classic picture. Complement deficiency, again, the Neisserial infections are usually what you'll see on board exams. Also, autoimmune type diseases in some of these conditions. And with leukocyte adhesion deficiency, again, you'll get that delayed separation of the umbilical stump, recurrent infections without abscess formation, but with none of these other conditions do you get the thrombocytopenia or bleeding complications. Question 19, regarding food allergy cross-reactivity, which of the following statements are false? A, most children with cow milk allergy can tolerate goat milk. B, children with peanut allergy are more likely to tolerate other legumes than tree nuts. C, shellfish allergy creates no higher risk for radiocontrast reactions compared to other allergies. And D, patients with pollen food oral allergy syndrome react only to the raw fruit or vegetable, not if it's cooked. Go ahead and key in your responses now. Okay, well, half of you got it right, because goat milk has virtually almost the identical allergenicity of cow's milk. Yep, and peanut allergy shows cross-allergenicity to other legumes like soybeans, and less than 10% of patients, or about 25 to 35% have tree nut allergy also. Goat milk is allergenic for approximately 90% of people with cow milk allergy, and shellfish allergy is caused by IgE-mediated sensitivity, whereas radiocontrast is not. And again, the pollen food oral allergy is a cross-reaction between the pollens and the fruits, and it really is a weak allergen that is only demonstrable with consumption of the raw fruit or vegetables. Cooking denatures this heat labile protein that's responsible for that allergy. Okay, going on the home stretch here. Question 20. A 12-year-old patient with severe asthma was admitted to the hospital for an acute exacerbation and has been treated with a variety of medications, including albuterol, over the past 24 hours. You are concerned that he might have symptoms related to albuterol toxicity. Which of the following is not a side effect of inhaled albuterol? A, muscle tremor, B, hypotension, C, hypokalemia, D, tachycardia, or E, nervousness? Go ahead and key in your answer now. Okay, yep, you got it right. I mean, you know, albuterol is a beta adrenergic agonist, so you're going to have the muscle tremor, you're going to have the tachycardia, you're going to have the nervousness. The other thing that you need to know is that hypokalemia is a side effect of albuterol toxicity. So if you're running somebody on continuous nebulizations, you need to monitor the potassium. But hypotension is not one of those adrenergic agonists. If anything, would cause hypertension if they were going to cause anything. So again, here's the clinical manifestations of beta agonists. Again, hypokalemia, tachycardia, muscle tremors, and cramps. Hyper, not hypotension, headaches, nervousness, dizziness. Question 21. A 13-year-old boy with a history of asthma and eczema developed frequent vomiting and episodic dysphagia 6 months ago. His symptoms did not improve after an 8-week trial of a proton pump inhibitor. You suspect he may have eosinophilic esophagitis. You refer him to a gastroenterologist and allergist for evaluation, and the diagnosis is confirmed. What treatment should be considered for this patient? A, oral cromolyn, B, montelukast, C, swallowed fluticasone or budesonide, D, recombinant tumor necrosis factor alpha, or E, a histamine 2 blocker. Go ahead and key in your responses now. Yep, I think most of you are right with the swallowed fluticasone or budesonide. Oral cromolyn has not been shown to have any effect in eosinophilic esophagitis. Montelukast has been tried and not been confirmed to have any beneficial effect and is not indicated. I don't know of anybody who's treating this disease with recurrent tumor necrosis factor, and histamine 2 blockers are not going to be any more effective than the proton pump inhibitor in somebody with the acid reflux associated with eosinophilic esophagitis. So, again, eosinophilic esophagitis is characterized by eosinophils in the esophagus, generally more than 15 per high-powered field on a biopsy, and they often present with feeding difficulties, vomiting, abdominal pain, and or dysphagia. And solid food dysphagia can occur in adolescents and older adults, where the most common presenting symptom is food impaction, where they actually have to yank some piece of meat out of your esophagus because it can't go down. These strictures form from the damage caused by the persistent disease. EOE is common with other allergic conditions, and symptoms often improve with treatment with swallowed fluticasone or budesonide and dietary exclusion of foods that may be exacerbating symptoms. Cow's milk, the most common associated with this EOE. Current guidelines do not support treatment with any of these other agents. Question 22. What's the best test for CGD? A, immunoglobulin, D, dihydrorhodamine reductase test, C, absolute neutrophil count, D, absolute T and B cells, or E, CH50. Key in your answers now, please. It's happening again. Yep. A DHR or NBT test would be the indicated test here for screening of CGD. So dihydrorhodamine is currently with flow cytometry, is currently the test of choice, although certainly nitroblue would be a reasonable choice for diagnosis of the disease. The DHR test is better for picking up carriers. Okay, question 23. The parents of a 6-month-old child present for a well child visit. He has eczema and egg allergy with a positive skin test after he had a reaction to scrambled eggs. No family history of food allergy, and he has a negative skin test to peanut. They ask you about introducing peanut into his diet. He sees his allergist next week, and his parents ask what the allergist might recommend. Of the following, the most likely recommendation of the allergist for this infant is to A, introduce peanut into his diet now to reduce his future risk for peanut allergy, as he is currently at increased risk for peanut allergy. B, introduce peanut into his diet now or later because he has no increased risk for peanut allergy. C, avoid peanut until age 12 months to reduce his future risk for peanut allergy. D, avoid peanut because he has over a 50% chance of developing peanut allergy if he doesn't wait until age 3. Or E, avoid peanut now because over 75% chance of developing peanut allergy if he doesn't wait until age 3. Key in your answers. Yep, give it to him now because he's at increased risk. Recent studies have shown that actually early feeding of allergenic foods, particularly peanut in the one study, in children who had atopic dermatitis and maybe another risk factor like another food allergy, actually had lower rates of peanut allergy when they were at age 5, when they started feeding it around age 6 months. And this was based on the LEAP study done in the UK, published in 2015. And so you saw the prevalence of peanut allergy in this group with severe eczema and egg allergy. In the avoidance group, in the peanut avoidance group, their future peanut allergy rates went up to 17.2 in this high-risk group, only 3.2 in the consumption group. So feed it early if they don't have the peanut allergy. 2 more left. Question 24. An 18-year-old boy with a history of allergic rhinitis has wheezing, generalized urticaria, and documented hypotension after a honeybee sting 8 weeks ago. After referral to the local allergist for venom skin testing, venom immunotherapy was recommended. Your patient wants to know what his chances are of having another life-threatening reaction in the next 5 years if he successfully completes the venom immunotherapy. The best answer is A, venom immunotherapy will be approximately 95% effective in preventing a future systemic reaction. B, it will be approximately 67% effective at preventing a reaction. C, since he has allergic rhinitis, immunotherapy will be less than 60% effective in preventing the reaction. D, since he had a severe anaphylactic reaction with hypotension, it will be less than 40% effective in preventing a future systemic reaction. Or E, you just can't predict. Go ahead and key in your answer now. Maybe you get out your crystal ball or something, right? But most of you got it right, yes. Venom immunotherapy, very effective at preventing future systemic reactions to bee stings. And so it clearly is the treatment of choice. And regardless of your clinical history, it's over 95% effective. Yep. Last question. Okay. You are seeing, and I apologize for the typo there. I usually am pretty good about picking that. You are seeing a 6-month-old infant with a recent history of treatment for gingivitis. His history is significant for a separation of the umbilical cord at 8 weeks of age. What immunodeficiency should you suspect? A, X-linked hyper-IgM syndrome, B, Chiari-Kagashi syndrome, C, leukocyte adhesion deficiency, or D, complement deficiency. Go ahead and key in your answers now. Yep, it's leukocyte adhesion deficiency. Again, you get that delayed separation of the umbilical cord, and you get gingivitis, oftentimes more with ulcerations than with actual pus or anything like that. And again, necrotic type things without abscess formation. Chiari-Kagashi, again, you get that, you get those obscenely large granules with infections with actual abscesses and pus. They also have partial oculocutaneous albinism. Hyper-IgM syndrome, not so much abscesses as regular infections with bacteria. And again, complement deficiency. Look for those Neisseria infections on the board exams, little autoimmune disease, but again, not so much the bacterial, not so much the abscess type thing. But again, none of these have delayed separation. So you see that factoid, you know it's leukocyte adhesion deficiency. Okay, there's my bibliography. Good luck, guys.